Mike. So like Mike said, my name is Jessica McKernan. I'm one of the solid tumor clinic pharmacists here at UW. And today we're going to be talking about targeted agents in lung and genitourinary malignancies. So our learning objectives for today, we're going to review medications used in the treatment of genitourinary malignancies, focusing on mechanisms of action, drug interactions, and side effects. We'll also discuss supportive care measures and management of some of these treatment-related toxicities. And lastly, we'll explore the use of targeted therapies in non-small cell lung cancer and focusing again on the mechanisms of action, drug interactions, and adverse effect profiles. There is a lot of material to go over today. There are a lot of targeted agents in non-small cell lung cancer and GU malignancies. So I'm going to do my best to hit the high points here. There is going to be more to look at on these slides than what I'm going to cover. It's there for you for your reference. Please feel free to reach out to me anytime after the presentation with any questions on those. So starting out with prostate cancer, our backbone of therapy is what we call androgen deprivation therapy, or ADT. So by the time a patient with prostate cancer gets to medical oncology, they're usually going to be on this, one of these agents are going to start on these agents. Androgen deprivation therapy is comprised of luteinizing hormone releasing hormone, or LHRH, or gonadotropin releasing hormone, or GnRH antagonists and agonists. The goal of these agents is to lower the testosterone to castrate levels with a goal serum testosterone of less than 50 after about a month of therapy. Now, the way that these two classes accomplish this is a little bit different. For our GnRH agonists, these actually stimulate the GnRH receptors, which increases FSH and LH and subsequently increases testosterone initially. So that creates part of our tumor flare that we'll talk about in a little bit. Over time, with chronic administration of these agents, that eventually activates a negative feedback loop, which essentially shuts down this pathway and decreases testosterone production. On the flip side, with your GnRH antagonists, these actually shut down those GnRH receptors up front, which decreases FSH and LH and subsequently decreases testosterone. So it happens much faster, more rapid suppression of LH and testosterone, and we do not see that tumor flare with those agents. So diving a little into these different agents, we have those LHRH agonists. This includes leuprolide and goserelin. I very rarely see goserelin used anymore just because it's an implant and we can see complications with injection. Most commonly, we use leuprolide. The IM version is called Lupron and the sub-Q version is called Eligard. And then we have our antagonists as well. So this is Degarelix, which is our sub-Q injection. And then we also have Relugolix or Govix, which is our oral formulation. Both of these antagonists do require a loading dose followed by maintenance doses. From a class effect standpoint, so if you think of depleting testosterone and the things that can happen there, we can see hot flashes, fatigue, arthralgias, and myalgias. We do worry about the long-term risks associated with that, including osteoporosis, particularly metabolic syndrome. So we can see increases in cardiovascular events, which we'll talk about. And we can also see increased risk of diabetes. I wanted to touch on a couple of differences between these classes, between the agonists and the antagonists. Like I mentioned, the agonists can have that tumor flare because of that initial surge in testosterone. So for patients who have a high burden of disease, a lot of overt metastases, this may not be the best option, or if we choose to move forward with an agonist, we do need to incorporate an anti-androgen as a lead-in, which we'll talk about in a moment. And because the antagonists block this production up front, we don't have that risk of tumor flare. So these are a good option for our patients with a high burden of disease. These also have a faster onset. So our antagonists have an onset of those castrate levels of testosterone within about 1 week, as opposed to our agonists, which takes about a month. So if you're looking for no tumor flare and a faster reduction in testosterone, an antagonist is a good option. Additionally, there's a lot of conversation and discussion around cardiac risk between these agents, with a lot of data suggesting that agonists may have a higher cardiac risk. And we'll talk about that in a moment as well. I do want to mention it is nice to have an oral option with Relugolix for the LHRH antagonist. That being said, sometimes insurance can restrict use of this agent, and we also have to be mindful of potential adherence concerns. The nice thing with injectables is we know the patient is getting the medication, so relugolix may not be the best option for patients who are concerned about compliance. So talking a little more about that tumor flare that I mentioned, it is caused by that initial surge in LH and FSH. This can present as increased bone pain and urinary symptoms, typically resolves in about 2 weeks. In order to combat this tumor flare, if we're starting with an LH-RH agonist, we typically want to use an anti-androgen or a first-generation anti-androgen lead-in to the agonist. This should be continued in combination for at least 7 days for patients with overt metastases to reduce those tumor flare symptoms. Oftentimes what this looks like in practice is that first-generation anti-androgen will be started about a week or 2 prior to the LH-RH agonist and then continued for anywhere from 2 to 4 weeks after that agonist is given. The anti-androgen that we typically use is bicalutamide or Casodex. And in a moment, I'll share some of the other agents, but this is preferred because of its better toxicity profile. I also mentioned the differences in cardiac risk between agonists and antagonists. There is a lot of data out there on this. There's a variety of studies looking at the differences between these classes. I do want to point out most recently in a cardio-oncology journal, they published a systematic evidence review and meta-analysis of about 11 trials, so over 4,000 patients. And this was just published this year. Long story short, they concluded that the quality of the data to definitively answer this question as to whether or not agonists have a higher risk of cardiac events remains suboptimal. However, the data overall does suggest that antagonists are associated with fewer cardiovascular events and possibly mortality compared to our LH-RH agonists. And I'm a visual person, so I think it helps to see this illustration they included in the article. Generally speaking, all of the data that has been compiled over the last 10 to 20 years is pointing towards and tipping towards the antagonist having a lower risk of those major adverse cardiac events compared to our agonists, which have a higher risk. I do think that it's important to consider this when we have patients coming in who are going to start on one of these agents and they already have a significant cardiac history. May be best to consider putting those patients on an LH-RH antagonist instead. Next, we have our androgen receptor antagonists. So these bind to the ligand binding domain of the androgen receptor. This inhibits androgen binding to that receptor, subsequently inhibits nuclear translocation, and prevents transcription of androgen receptor target genes that are involved in cell growth and survival. So our first generation androgen receptor antagonists, these really aren't used too much anymore. Like I mentioned, we do use bicalutamide, but that is in the setting of a lead-in to that agonist to reduce tumor flare. This is typically dosed at 50 milligrams once a day. Typically well tolerated, maybe some diarrhea or hematuria, but not common. If we do start patients on this agent, it's important to monitor LFTs. If this agent is on more longer term, it can eventually develop into an agonist because of resistance mechanisms, and you can actually start to see the PSA rise transiently. If you pull off that bicalutamide, you should see a decline in the PSA. Next, we have our second generation androgen receptor antagonists or anti-androgens. This includes apalutamide or Erleada, darolutamide or Nubeqa, and enzalutamide or Xtandi. Apalutamide is dosed at 240 milligrams once a day with or without food. There are a lot of drug interactions with this agent. It is a major 2C8 substrate. It's also a 3A4 and 2C19 inducer. So a lot of opportunities for drug interactions, particularly for medications that a lot of our older male prostate patients are on. So things like statins, anticoagulants, clopidogrel, calcium channel blockers, and several others. The most common side effect of apalutamide is fatigue. We can also see rash and hypothyroidism. Of note, the apalutamide trials did exclude patients with a history of seizures, so would not recommend this agent in a patient with a history of seizures. For darolutamide or Nubeqa, this is dosed at 600 milligrams twice a day. This is given with food. We can see drug interactions with this agent, but not as much. Rosuvastatin is one that stands out to me, but generally speaking, compared to these other second-generation anti-androgens, not as many drug interactions. We can still see fatigue as well as hypertension and rash. Of note, this one does have poor blood-brain barrier penetration, so this is your best option for a second-generation anti-androgen for patients with a history of seizures. Lastly, we have enzalutamide or Xtandi. This is dosed at 160 milligrams once a day. This is given with or without food, and again, a lot of drug interactions, very similar to apalutamide. The most common side effect is fatigue, and again, trials excluded patients with a history of seizures. Next, we have abiraterone. This is a CYP17 inhibitor, and CYP17 is an enzyme that's required for androgen biosynthesis. So if you look at the diagram on the right, you can see that by inhibiting CYP17, we're inhibiting some of those testosterone precursors, and as a result, decreasing the production of testosterone overall. You can also see one of those pathways for those precursors eventually produces cortisol. So when we're inhibiting CYP17, we're also decreasing cortisol. As a result, there's a compensatory increase in ACTH and a subsequent accumulation of steroids with mineralocorticoid properties. So these patients can develop mineralocorticoid excess. What we need to do is replace that cortisol with prednisone, and that helps mitigate some of those mineralocorticoid effects, such as hypertension, hypokalemia, and fluid retention. So when I'm educating patients on abiraterone, I'm always reinforcing if they are taking their abiraterone, they also always need to be taking their prednisone to mitigate side effects of abiraterone. Abiraterone comes in two different formulations. One is called Zytiga, and the other is Jansa. I'm not going to talk about Jansa today as it's very rarely used, but here for your reference. Our most common abiraterone formulation is Zytiga, dosed at 1,000 milligrams once a day. It is taken on an empty stomach. Most common side effects with this one include hypertension, fatigue, and increased LFTs. We do need to watch those LFTs closely. Typically, what we will do for patients starting on abiraterone is monitor those LFTs for at least every 2 weeks for the first 3 months, and then we can back off on that frequency based off of trends. So where do all these agents fit into therapy and treatment of prostate cancer? For abiraterone, currently that is not approved in non-metastatic castrate-resistant prostate cancer, but it is approved in our other metastatic settings. Darolutamide and apalutamide both do not currently have an indication for metastatic castrate-resistant prostate cancer. Both abiraterone and darolutamide have approvals in combination with docetaxel in our metastatic castrate-sensitive prostate cancer patients. And the most recent development, and this is actually in the last 4 to 5 months or so, is approval of combinations of these agents with PARP inhibitors. So abiraterone was recently approved in combination with olaparib for BRCA-mutated metastatic castrate-resistant prostate cancer. It's also recently been approved as a combination pill with niraparib called Akega. And again, that's a BRCA-mutated indication for metastatic castrate-resistant prostate cancer. Enzalutamide has also been approved in combination with talazoparib. And this is specifically for patients with homologous recombination repair gene-mutated metastatic castrate-resistant prostate cancer. So I think we'll start to see these combinations a little more frequently in patients with these mutations. A couple of things to consider in these patients, and we've covered this a little bit. Drug interactions are big, particularly with our second generation androgen receptor antagonists like apalutamide and enzalutamide. Of note, these are our older male patients, so a lot of these patients can have a cardiac history and be on a lot of the medications that we worry about interactions with. So things like statins, calcium channel blockers, antiplatelets, anticoagulants, PPIs, and many more. So please don't hesitate to reach out to your clinic pharmacist, specifically for apalutamide and enzalutamide because of the vast array of drug interactions that we can see. As soon as I know we want to start a patient on it, I will try to proactively review interactions so we can come up with a plan to manage those prior to starting. But I also, with every education of oral chemotherapy, I meet with these patients and go through their medication list and review these interactions to make sure that these are safe to take together. There's also a significant financial toxicity and burden in these patients. So again, our older patient population, a lot of these patients are on Medicare. Those second generation androgen receptor antagonists can be difficult to find an affordable avenue. We cannot use standard copay discount cards because of government insurance. And then we do have some medication assistance programs and grants, but if a patient does not meet the income eligibility, the copays can be very high, and this can have a significant impact on their treatment. Abiraterone, unfortunately, does not have any medication assistance programs or grants anymore. We do have some more affordable options through Cost Plus Drugs and Costco. This can run anywhere from $150 to $300 a month, which may or may not be something that's feasible for our patients. And Cost Plus Drugs does require the ability to use the internet and computers, which can be a barrier for patients. So all things to keep in mind in our patients that we're starting on these oral targeted agents in prostate cancer. Next, we'll talk about targeted agents in urothelial carcinoma. Our first agent is erdafitinib or Balversa. This is an inhibitor of FGFR. So this is specifically for patients who have FGFR2 and FGFR3 alterations. This agent also inhibits, so we have FGFR on our renal proximal tubules in our kidneys. And when we inhibit that FGFR, it actually prevents reabsorption of phosphate. So we have a lot of trouble with hyperphosphatemia in these patients, up to 76%. And there's specific dosing guidance for this. So the initial dosing is 8 milligrams once a day. Then what we will do is check a serum phosphate level about 2 to 3 weeks after we start therapy. And if the phosphate is less than 5.5 and we don't have any other major toxicities, we can increase that dose to 9 milligrams once a day. This can be taken with or without food. Of course, from a drug interaction standpoint, we want to avoid concomitant agents that can increase our phosphate levels, things like vitamin D or antacids. And this is most important in that initial dose increase period. So right before that, at days 14 to 21, where we want to completely avoid those agents. We can see other drug interactions because this is a CYP3A4 and CYP2C9 substrate. Like I mentioned, hyperphosphatemia is common with the median onset of about 20 days. And we can also see ocular toxicities, particularly dry eye syndrome. So very important to educate these patients on the use of artificial tears as needed. There is good guidance on how to manage this erdafitinib-induced hyperphosphatemia. So for levels of 5.6 to 6.9, we do not need to make any changes. We can continue at the same dose and continue to monitor phosphate monthly. Where we need to start considering changes is when those levels are above 7. So for a phosphate of 7 to 9, we need to hold erdafitinib, assess phosphate weekly. We can consider initiating an oral phosphate binder until those levels are less than 5.5. And once those levels are less than 5.5, we can restart erdafitinib at the same dose. Unless hyperphosphatemia persists for more than a week, then we need to consider a dose reduction. For phosphate over 9, again, we need to hold erdafitinib and assess those phosphate levels weekly. When phosphate is back down to less than 5.5, we can reinitiate erdafitinib at the next lower dose level. For a phosphate over 10, or for grade 3 hypercalcemia or significant changes in baseline renal function, again, we would hold our erdafitinib and assess those phosphate levels weekly. When those levels are back down to less than 5.5, we can restart erdafitinib, but this needs to be at 2 dose levels lower. Next, we have enfortumab vedotin, or Padcev. This is an antibody drug conjugate, which means it has a monoclonal antibody attached to a cytotoxic agent. In this case, this is a Nectin-4 monoclonal antibody. And Nectin-4 is found in a variety of cells, particularly in the bladder, and can also be found in the skin, which is why you can see some of the skin toxicities listed here. That Nectin-4 monoclonal antibody is bound to a microtubule disrupting agent called MMAE. When Nectin-4 binds to the cell surface and is internalized, that MMAE is released from Nectin-4 from the antibody, and then exerts its effect as a microtubule disruptor and causes cell cycle arrest and apoptosis. We can see those skin toxicities in up to 55% of patients with grade 3 skin reactions as well. And we can also see ocular toxicities, including dry eye syndrome. So again, important to instruct patients on using artificial tears. And if this were to worsen with the use of artificial tears, we would want to hold treatment and consider the use of steroid eye drops. As I mentioned, that MMAE is a microtubule disruptor, and that is very similar to our taxanes. So it also shares a side effect profile with taxanes. So we can see peripheral neuropathy and bone marrow suppression. Lastly, we can also see hyperglycemia, and the mechanism of this is not fully understood, but we do need to monitor blood glucose closely. If a patient's blood glucose is over 250 and we cannot get that under control with antihyperglycemics, we do need to hold enfortumab until that's improved, and then we can resume at the same dose. So I wanted to talk a little more about that enfortumab-induced rash that I mentioned. So like we discussed, enfortumab targets Nectin-4, and Nectin-4 is also expressed in the skin. And the way that Nectin-4 works in the skin is it is involved in cell adhesion. So the thought is if we are impairing the cell adhesion, this can lead to epidermal detachment. It has been documented that MMAE itself can exert direct skin toxicities and irritation as well. Typically, this rash is a maculopapular rash and can have some pruritus as well. It presents as an erythematous, scaly, pruritic papules, and it's predominantly located in the skin folds, hands, and the feet. Typically, we will see this within the first month of treatment. The key to this rash is prevention and minimizing risk up front. This can be accomplished by using things like sunscreen and UV protection, reviewing barrier agents or zinc-containing moisturizers and applying those to the skin folds, recommending moisturizing the skin once to twice a day, avoiding things that are inherently irritating to the skin, things like hot water, fragrance products, alcohol-based products, harsh chemicals, and of course, performing routine skin assessments prior to each treatment. For our grade 1 or 2 rashes, the recommendation is to start topical steroids as well as topical antibiotics. We can also add oral antihistamines. And for our grade 2 rashes, we can consider adding oral antibiotics. For our grade 3 rashes, the recommendation is to hold treatment until it's down to a grade 1, and then we can resume at the same dose or consider reducing by 1 dose level. We also start oral steroids in these patients for at least 2 weeks and consider a derm consult as well. Liz may have mentioned this to you guys in the last presentation or two, but we do have wonderful oncoderm here at UW, so please utilize them when you need to. For our recurrent grade 3 or grade 4 rashes, the recommendation is to discontinue treatment. Often this requires inpatient management. Of course, we would want a derm consult, and if we are concerned about the more severe reactions like Stevens-Johnson syndrome, a biopsy is recommended. Our next agent is sacituzumab govitecan, or Trodelvy. Now, I believe Liz went over this with you guys, so I'll just touch on some high points and reinforce some things that she discussed. Again, this is an antibody drug conjugate. This is a TROP2 monoclonal antibody, and it's coupled with a topoisomerase 1 inhibitor, SN38, which is the active metabolite of irinotecan. So this shares a very similar side effect profile to irinotecan, predominantly neutropenia and diarrhea. There also is a high risk of infusion reaction, so about a third of patients react to sacituzumab. So we do pre-medicate all these patients with Tylenol and H1 and H2 antagonists. About 39% of patients in the trophy trial did have a dose reduction for these more common side effects like neutropenia and diarrhea. And about a third of them also needed that secondary prophylaxis with growth factor support starting with cycle 2. The other thing to keep in mind for these patients is it does have a moderate emetic risk, but this can escalate quickly to more of a high risk emetogenicity. So we have a very low threshold to adding IV aprepitant for these patients. Next, we'll talk about renal cell carcinoma. So as far as targets in renal cell carcinoma, Renal cell does not respond well to our traditional chemotherapy. So we have pivoted to primarily things like VEGF, tyrosine kinase inhibitors, or TKIs, and immunotherapy. And we'll also use these in combination, and we'll talk about that. And a lot of our VEGF TKIs also have off-target effects, so we can see a lot of side effects. These are oftentimes multi-targeted tyrosine kinase inhibitors, and we'll talk about those a little bit more as well. Of course, because of all of those off-target effects and all these other receptors that these VEGF TKIs may target, we can see a variety of side effects, and these agents can be particularly difficult to tolerate. And we'll break down some of those side effects shortly. I did want to briefly touch on some of the older agents that we've used in renal cell. So back in the earlier to mid 2000s, we used agents like sunitinib and pazopanib, which are VEGF TKIs, but they have other targets listed there as well. I think the biggest challenge with these is they were extremely difficult to tolerate. They're still listed in the NCCN guidelines. They can be considered as another recommended regimen. However, they don't have the preferred or category 1 designation anymore because we have trials showing agents with improved survival. So some of those agents are listed here. Some of the newer agents include cabozantinib or Cabometyx and axitinib or Inlyta. Cabozantinib is dosed on its own at 60 milligrams once a day. When we combine it with nivolumab, that dose is reduced to 40 milligrams once a day. It is taken on an empty stomach. You can see there it does target VEGF, but it also has other targets as well. It is a major 3A4 substrate, so opportunities for drug interactions there. Most common side effects include fatigue, hand, foot, skin reaction, and hypertension. Although I will say overall, this is definitely one of the more difficult agents to tolerate. That 60 milligram dose in particular can be difficult for our patients to tolerate. We're often seeing dose reductions with cabozantinib. One of the perks of cabozantinib is it also inhibits MET, and this is a common mechanism of resistance to VEGF TKIs. So this is a good option in that space. A downside to cabozantinib is its half-life. So it's about 100 hours. When I meet with patients and I'm talking to them about cabozantinib, I'm always stressing the importance of them letting us know if they have an upcoming procedure at any point, because we need to hold this agent for at least 3 weeks prior to surgery. And that's because of that VEGF inhibition, and we'll talk more about why in a bit. The other agent that we have is axitinib or Inlyta. This is dosed at 5 milligrams twice a day and can be increased to 7 milligrams twice a day, followed by a max of 10 milligrams twice a day if tolerated. This can be taken with or without food. One of the benefits to axitinib is it is a selective VEGF inhibitor, so it's only targeting those VEGF receptors. So lower risk of side effects, a little bit better tolerated. Still a major 3A4 substrate, so being mindful of interactions. More common side effects include hypertension, fatigue, and diarrhea. A positive to axitinib, and I think a lot of providers like this, is that its half-life is very short. It ranges from 2.5 to 6 hours. So we have the ability to quickly turn it on and off if we need to, and it's also more convenient for patients who need to have procedures. We also have lenvatinib or Lenvima and tivozanib or Fotivda. So lenvatinib is dosed at 18 milligrams once a day in combination with everolimus, and it's actually dosed at a higher dose level of 20 milligrams once a day when combined with pembrolizumab. This can be taken with or without food. Can see a variety of targets there in addition to VEGF. Typically not too many drug interactions with lenvatinib, but we can see hypertension, fatigue, arthralgias, and myalgias. This is another agent I think of that can be particularly difficult to tolerate. Of note, I did want to mention this agent is supplied in therapy packs. So for example, if you're supplying a 14 milligram daily dose, it comes in a pack with 10 milligram tablets and 4 milligram tablets. So I'm also educating patients on that when I meet with them. Lenvatinib has a half-life of about 28 hours, so we need to hold this agent for at least a week prior to surgery. Tivozanib is our newest VEGF inhibitor. It has a very specific dose of 1.34 milligrams once a day, and this is also cyclical. So the rest of the agents I've been talking about are all continuous with no breaks. But tivozanib is on a 21-day regimen. You have a week off and then you start that cycle again. So it's given on days 1 through 21 of a 28-day cycle. This can be taken with or without food. It is a major 3A4 substrate, so we can see more drug interactions with this one. Again, common side effects very similar to the others: fatigue, hypertension, and diarrhea. Tivozanib does rival cabozantinib's half-life. It's actually even longer at 111 hours. So the package insert recommendation is to hold for at least 24 days prior to surgery. Again, very important to stress to patients to let us know if they have any upcoming procedures. So I mentioned a little while ago that we use immunotherapy for renal cell carcinoma as well. We really don't see much response with traditional chemotherapy. And we've actually found that combining immunotherapy with VEGF inhibitors has also shown improved survival rates. The combinations that have been approved include axitinib with pembrolizumab, cabozantinib with nivolumab, and lenvatinib with pembrolizumab. A little background on how these work together. So VEGF inhibits the innate and adaptive immune system, and it also upregulates the expression of PD-1 and CTLA-4 on the immune cells. So these agents do work well together and improve survival outcomes. As far as which combination to use, this really comes down to provider preference. The one thing to consider is we do see that higher dose of lenvatinib in combination with pembrolizumab, and this has led to difficulty in tolerating this combination. So almost 70% of patients require dose reductions of lenvatinib when on this combination. So just something to keep in mind. And I have seen some preference for axitinib with pembrolizumab, again, due to that shorter half-life with axitinib and that quick on-off if we need to use it. Circling back to some of those class effect toxicities of VEGF inhibitors. So we've been talking about using VEGF inhibitors around surgery, and that's because of the bleeding complications that can happen. We can see GI perforations and also poor wound healing. So these VEGF inhibitors impair wound healing. It takes longer to recover from surgery. We can also see thrombotic events, hypertension, proteinuria, and hand-foot skin reactions. So how do we manage VEGF inhibitor hypertension? This can happen relatively quickly. We can see this within the first 2 weeks of treatment with a median onset of about a month. There are a few risk factors for this, and this is seen in a lot of our patients. So BMI over 25, age over 60, of course, pre-existing hypertension as well. So the recommendation is to monitor blood pressure once daily to start. I would recommend doing this at least for the first cycle or the first month of treatment. And then based off of trends, we can talk about peeling back that frequency. We do need to initiate antihypertensives if blood pressure is consistently greater than 140 over 90. We also need to hold the VEGF inhibitors if treatment is, if the blood pressure is more than 160 over 100, or if we're unable to control blood pressure with antihypertensives. There is data to support specific antihypertensives and their use in this space. The first line choice is our calcium channel blockers like amlodipine. For patients who do have concomitant proteinuria, which can happen with our VEGF inhibitors, the recommendation is to use an ACE inhibitor or an ARB, so considering agents like lisinopril or losartan. These hand-foot skin reactions that I mentioned present as defined hyperkeratotic lesions on the hands or the feet. Symptoms typically include things like burning, dysesthesia, paresthesia, tingling on the palms and the soles of the feet. These can be callus-like blisters. The skin can become very dry, even cracked. We can see edema, erythema, even desquamation. Typically, this is seen earlier on in treatment, so within the first 2 to 4 weeks. Again, just like that enfortumab-induced rash, the key here is prevention of hand-foot skin reaction. So there's a lot of things that we can do and educate on to minimize risk up front. We recommend gentle exfoliation of the hands and feet prior to treatment, moisturizing once to twice a day, avoiding vigorous exercise or repetitive activities that can stress those hands and feet. Also avoiding things that are irritating to the skin, like hot water, again, harsh chemicals, fragrance products, alcohol-based products, things that can dry out the skin. Also avoiding constrictive footwear and using padded insoles when able. And also wearing thick cotton gloves or socks at night, putting over that moisturizer to keep that moisturizer in overnight. For our grade 1 hand-foot skin reaction with minimal skin changes and no pain, the recommendation is to moisturize twice a day. Again, wear those cotton gloves and socks at night. We can apply cold packs for relief as needed and consider topical steroids. For grade 2 hand-foot skin reactions, consisting of things like blisters, peeling, pain, things that are limiting instrumental activities of daily living, the recommendation is topical steroids twice a day to those erythematous areas. We can also employ things like topical lidocaine, NSAIDs, and Tylenol to manage pain. For grade 3 hand-foot skin reaction, which would consist of severe skin changes, pain, things that are limiting our self-care activities of daily living, we recommend holding treatment for at least 7 days until improvement. We can consider the addition of topical antibiotics for any blisters or erosions. We can also consider oral antibiotics if we swab any of those wet lesions. And we would also want to consider escalating pain management as needed. Last but not least, for renal cell carcinoma, another targeted agent is belzutifan or Welireg. So this is dosed at 120 milligrams once a day with or without food. It is a small molecule inhibitor of hypoxia-inducible factor 2 alpha, so HIF. And when we inhibit HIF, we decrease gene transcription, and this leads to reduced erythropoietin production and iron metabolism. This also prevents oxygen sensing regulating genes from promoting the body's response to hypoxia. As a result, our most common side effects with this agent are anemia and hypoxia. So this requires frequent monitoring of hemoglobin and oxygen saturation. The median time to onset of anemia is about 31 days. If hemoglobin is less than 9, or if a transfusion is indicated, we need to hold treatment until hemoglobin is over 9, and then resume at either a reduced dose or even consider permanently discontinuing treatment depending on the severity. This agent is only indicated for treatment of von Hippel-Lindau disease or VHL disease that's associated with renal cell carcinoma. And last but certainly not least, we'll talk about our targeted agents in lung cancer. There are a variety of targeted therapies in non-small cell lung cancer, and this is an ever-growing field. I think this is really fascinating, the number of targets that we've been able to discover and find agents for. There's a variety of mutations that we'll talk about. Compared to those VEGF TKIs that we talked about in renal cell, these agents are much more selective, so a little bit better tolerated overall, and we'll talk about what those look like. I will not go over all of these agents, but I did want to list the ones here that are included in our guidelines. There are a variety of different mutations that we can target. Very generally speaking, if we have a patient who presents to us on initial presentation with metastatic non-small cell lung cancer, if we discover a target with next generation sequencing, generally we want to aim for that target, and that will be our first line of treatment. There are some exceptions to that are annotated with an asterisk here that are indicated for subsequent treatment after chemotherapy or chemoimmunotherapy. But know that there's a lot of targeted agents out there that we can use if we find a therapeutic target in NGS. We have our EGFR exon 19 deletions, as well as exon 21 mutations. We also have EGFR exon 20 insertion mutations. So a variety of EGFR mutations. We also have a KRAS G12C mutation, ALK rearrangements, ROS1 rearrangements, things that you see in other disease states like BRAF V600E mutations, NTRK gene fusions, MET exon 14 skipping mutations, which is pretty unique to non-small cell lung cancer. There's a lot of current development in high levels of MET amplification. I anticipate we'll see approval in that space for these agents soon. We can also see RET rearrangements as well as HER2 mutations. So starting with EGFR or epidermal growth factor receptor mutations, we can see this in about 15% of the non-small cell lung cancer Western population and up to 35% in the Asian population. Now the downstream pathway to EGFR is that RAS, RAF, MEK, MAP kinase pathway. that leads to cell proliferation, growth, and survival. You will see that as a common theme throughout with many of these mutations in non-small cell lung cancer. The EGFR mutations in particular are typically seen in never smokers. Up to 90% are exon 19 deletions or exon 21 point mutations. And of note, exon 18 and exon 20 mutations are usually less sensitive to our traditional EGFR TKIs. There are several EGFR inhibitors available, but I did want to highlight the two that we most commonly see in practice. The first one is erlotinib or Tarceva. This is dosed at 150 milligrams once a day on an empty stomach. There are several potential drug interactions, including acid suppressants. The most common side effects with these agents is our rashes and diarrhea. Something really unique to erlotinib is smoking can actually decrease the levels of erlotinib in the body. So for our patients who are going to continue to smoke while they're on treatment, it's very important to educate them and talk to them about whether or not they're going to continue smoking or stop smoking. If they're going to continue smoking, we have to increase this dose up to a total of 300 milligrams once a day. So essentially double the standard dose. And they do need to let us know if they quit smoking so that we can adjust that dose back down and minimize their risk of side effects. Osimertinib or Tagrisso is by far the most common EGFR inhibitor that I see in practice. It's dosed at 80 milligrams once daily. It does have CNS penetration and is approved for patients with CNS metastases. There is an off-label dose available of 160 milligrams once a day. Unfortunately, we do have a hard time getting insurance to pay for that, but know that that can be a potential option for your patients. This is taken with or without food. Again, it's a major 3A4 substrate, so opportunities for drug interactions. And most common side effects with these EGFR inhibitors include rash and diarrhea. Osimertinib in particular does carry a risk of QT prolongation, particularly in patients that already have a risk at baseline. So if a patient does have those risk factors, we do recommend a baseline EKG with periodic monitoring throughout treatment. Cardiomyopathy is also a potential risk, albeit low. It's still important to get a baseline echo in these patients with monitoring throughout treatment. Like I mentioned, this agent has good CNS penetration. It also has activity against a resistance mechanism or mutation to EGFR inhibitors called T790M. And overall, this is the drug of choice for our exon 19 and 21 mutations based off of overall tolerance as well as that CNS penetration. Next, we have our ALK or anaplastic lymphoma kinase mutations. Specifically, a fusion is an inversion of EML4 and the ALK genes, which create this novel fusion oncogene. This is seen in about 2 to 7% of patients with advanced non-small cell lung cancer, generally seen in our younger population and often seen in never smokers. We do, again, have a variety of ALK inhibitors. I won't go through all of those, but did want to highlight two that I more commonly see in practice. The first is alectinib or Alecensa. This is dosed at 600 milligrams twice a day with food. Not too many drug interactions with this one, but we can see LFT elevations. I did want to note, we can see bradycardia with this agent, which is not too common, but I do think it's important to educate patients on symptoms to watch for. And this one does have good CNS penetration. Lorlatinib is our third generation ALK inhibitor. Lorlatinib or Lorbrena is the brand name. It's dosed at 100 milligrams once a day, can be given with or without food. You can see there's a variety of other targets with lorlatinib, so can be more difficult to tolerate, is a major 3A4 substrate, so opportunities for more drug interactions there. By far, the most common side effect with this agent is hyperlipidemia, and you can see those numbers there. It's essentially almost all of our patients on this agent will experience some level of increase in cholesterol or triglycerides or both. We can rarely see cognitive effects. Seizures were reported in about 3% of patients, so important to educate on that. I was mentioning that hyperlipidemia, this is the only ALK inhibitor that causes those cholesterol changes. This is not a class effect that's specific to lorlatinib. We'll talk about how to manage that in just a moment. As a third generation ALK inhibitor, lorlatinib also can overcome some known ALK resistance mutations, which makes this a good option for second line therapy and also has good CNS penetration. So I mentioned that lorlatinib induced hyperlipidemia. There is data with good guidance on how to manage this. For patients with mild or moderate hyperlipidemia, we recommend introducing or modifying lipid-lowering therapy, but you can continue lorlatinib at the same dose, and there's a pretty high threshold for that. For patients with severe elevations in cholesterol or triglycerides, we want to introduce lipid-lowering therapy if that's already on board, either increasing the dosage or adding a new lipid-lowering agent. And we can still continue lorlatinib at the same dose. PEGGINSER does not recommend any dose interruptions or decreases at this point. Really, where we need to make changes is for life-threatening elevations. Of course, if we don't already have lipid-lowering agents on board, we need to add those and consider modifications to those as needed. And then we will hold lorlatinib until hyperlipidemia is down to moderate or mild grade before re-challenging at the same dose. And this can be done while maximizing lipid-lowering therapy. However, if severe hyperlipidemia recurs despite maximal lipid-lowering therapy, we recommend reducing lorlatinib by 1 dose level. As far as lipid-lowering therapy goes, typically we will start with statins. A variety of statins do interact with lorlatinib, so typically my preference is starting with rosuvastatin. Plus with rosuvastatin, you have a wider range of dose adjustments. If this is not responsive to maximal doses of rosuvastatin, we can add on agents like fenofibrate, fish oil, or ezetimibe. Next, we have KRAS or Kristen rat sarcoma mutations. This is the most common mutation seen in about 25% of patients with non-small cell lung cancer in the North American population. And this is generally associated with smokers. We do have 2 KRAS inhibitors approved in non-small cell lung cancer. The first is sotorasib or Lumakras, dosed at 960 milligrams once a day. It does specifically target that KRAS G12C mutation. Can be taken with or without food. A lot of drug interactions with these agents, including acid suppressants, so something to be mindful of. More common side effects with this agent include things like diarrhea, myalgias or arthralgias, and elevated LFTs. One thing to note is the first dose reduction is pretty significant. So if we do need to dose reduce, it's actually a 50% dose decrease down to 480 milligrams. Our newest agent on the block is adagrasib or Krazati. It's dosed at 600 milligrams twice a day. Can be taken with or without food. Again, a lot of potential drug interactions. This is also a strong 3A4 inhibitor, so a lot of opportunities for drug interactions. Very important to review med lists before starting this agent. As far as side effects goes, we can see a pretty high incidence of QT prolongation. So the recommendation is to get a baseline EKG and monitor periodically throughout treatment. Can also see diarrhea, elevated LFTs, and myalgias or arthralgias. And this agent can increase that QTC more than 60 milliseconds, which is pretty significant, just again reinforcing the importance of EKG monitoring. Next, we have our MET or mesenchymal epithelial transition factor mutations. So we have MET gene amplifications, and then we also have exon 14 skipping mutations. The MET exon 14 mutations are found in about 3 to 4% of patients with non-small cell lung cancer and are more frequent in our older women and never smokers. We do have 2 agents approved in this space, and these have both been approved in the last couple of years, back in 2021. The first is capmatinib or Tabrecta. This is dosed at 400 milligrams twice a day with or without food. It's a very selective inhibitor. We can see some drug interactions with this one. Tepotinib or Tepmetko is dosed at 450 milligrams once a day and must be taken with food. Fewer drug interactions with this one. They have very similar side effect profiles. The most common side effect is typically edema. And the edema with this is not just in the lower legs, ankles, feet. We can see this in the face. We can see this in the hands, a variety of other areas. So important things to monitor for. We can also see fatigue, arthralgias, myalgias, and increased creatinine. One thing to note is there are coexisting MET amplifications in EGFR mutated non-small cell lung cancer. And there's quite a bit of data looking at combinations of these agents to overcome resistance to EGFR TKIs. So I think in the future, we're going to see combinations of some of these agents. Next, we have RET or rearranged during transfection mutations. RET rearrangements are found in only 1 to 2% of our non-small cell lung cancers, typically found in current and former smokers. We do have 2 RET inhibitors approved. The most common one I see prescribed is selpercatinib or Retevmo at 160 milligrams twice a day. For our really small patients, we rarely see this, of course, but we do need to be mindful of decreasing the dose to 120 milligrams twice daily. This can be given with or without food. However, if we are going to keep concomitant acid suppressants on board, we do need to give it with food. You can see it has other targets outside of RET and a variety of drug interactions to watch for. Common side effects with this one include edema, hypertension, QT prolongation, fatigue, and hypersensitivity reaction. Now, the hypersensitivity reaction is rare, but this is uncommon to see in an oral agent. The package insert describes this as fevers, rash, and myalgias or arthralgias, so keep that in mind for patients presenting with those symptoms. This does have CNS penetration and also needs to be held prior to surgery. And then we have pralsetinib or Gavreto, dosed at 400 milligrams once a day on an empty stomach. Again, a variety of targets outside of RET with potential for drug interactions. Most common side effects include hypertension, LFT elevations, and fatigue. Also has CNS penetration and needs to be held prior to surgery. Last but not least, we have our NTRK or neurotrophic tyrosine receptor kinase fusions. So these NTRK gene fusions encode tropomyosin receptor kinase fusion proteins, and those act as oncogenic drivers. This is seen in a very small percentage of patients, only 0.2% of patients with non-small cell lung cancer. We do have 2 inhibitors approved in this space, larotrectinib and entrectinib. Larotrectinib is dosed at 100 milligrams twice a day. Of note, there is an oral solution available, can be given with or without food, potential for drug interactions. Most common side effects with these agents is CNS effects. And the onset of this is typically a few months into treatment, so about 5 to 6 months in. So this can be delayed, and that's important to monitor for as well. Entrectinib is also approved for ROS1 mutations as well, so can be used in a different setting in addition to NTRK fusions. So there are a lot of emerging biomarkers in non-small cell lung cancer. We've seen rapid growth with the oral targeted therapies in the last 5 to 10 years, and I think this is going to continue. So more to come there. In conclusion, our targeted therapies in our genitourinary and our non-small cell lung cancer tumors are constantly growing and evolving. A lot more to come there. There's going to be changes even from this discussion last year. There's been a lot of updates. And there are, as you can see, a lot of drug interactions and a variety of toxicities. So please reach out to your clinic pharmacist. We're here to help.